on there?
Yeah, that's okay, because the first two and then the third one and then, all right. Are we ready?
Yeah, go ahead. Put that close to here so you can hear.
Okay,
Sorry,
so
Katie.
for,
I'll be on
so for the nurses meeting, today, just wanted to go over three really, brief things. One thing is, you know how we have the new diet system, the ITSE system? I think you had to like look at Erica's video and all that stuff. You may have already noticed that on the room name tag plates, there are two dots now. And that just mirrors, what is that noise?
It's that computer.
Okay, that mirrors the, it's the color coding. And whatever is on the door of the resident is what their food and their liquid consistencies are supposed to be. It's not what the therapeutic diet is, meaning it doesn't mean that, it won't tell you that they're on a low sodium diet or if they're on the renal diet or anything like that. This just has to do with whether or not it's regular texture, puree. For example, for the foods and for the liquids, it has to do with thickened, mildly thickened, slightly thickened, or whatever the ITSE thing is. Now, because even I can't remember, John took it upon himself, and this is wonderful. I think he just showed it on the video. We are gonna get those laminated so that we can have it on our badges, just like the safety ones, right? And on the other side is what we do for our red dot residents who are the florists. I mean, obviously, every resident on this unit has the potential to, you know, fall. But the red dots for us means that they have had a fall or they've had falls in the past, so that, you know, we need to keep a better eye on them and also do the red dot protocol, which is the 4 Ps, and that is going to be on that little laminated badge thing as well. So if you're wondering what the dots are on the nameplates, the left one has to do with the food consistency and the right one has to do with the liquid. Now, this goes more for the South Hall because these are our rehab residents. What really prompted this, and I, you know, got a bug in my bee in my bonnet or whatever, and I really wanted to do this, was because oftentimes family members will come in, and even if the residents on thickened liquids, they'll bring in something, and you know, it'll be just thin liquids. So at least if the staff, it's right in front of our face, and it will take a little while for us to memorize the colors, but it will become second nature after a while. Then we can stop the family members from leaving it, or if we see it, we can just take it out, okay? Again, this isn't a perfect solution, but it should, I am hoping that it will lead to better care for our residents. Number 2, the Medicare charting. We're going to have to just do better, and this is what I wanted to actually ask my colleagues, every one of you, because I know, for example, Barbara tried to put in the templates. We're having a real hard time getting a template where you can like just kind of cut and paste or copy and paste, but we've got to up our game somehow, and that has to do with whatever their admissions, and this goes specifically for the rehab patients here, whatever their admitting diagnosis is, that's what we have to address. So for example, if somebody comes in here with congestive heart failure, oftentimes I'll see notes just saying, you know, patient comfortable, you know, no distress, continues with PTOT, you know, ST. That's not good enough.
I mean,
We have to address.
And then I made some
What?
examples. I'll go over that real
Is
quick
this-
as well.
Okay,
This is what it gets
then John will go over that a little bit more, but what I did wanna tell you guys is, the reason why I'm doing this, you know, bringing this up again is because Dr. Mon, our medical director, was telling me that Carlsbad by the Sea, they had the feds, not the state, but the feds, the CMS people come in and do a audit of their Medicare patients, which obviously involved looking at nurses' note as well. Now, the only reason that these people are really coming in is not to give us gold stars, but there can be real consequences where they're going to deny payment retroactively. I mean, we give such great care. I don't want us to, let me backtrack. So CHF patient, obviously as nurses, we're going in there, we're seeing if they're, having edema, shortness of breath, we're doing all these assessments anyway. We're just not writing it down, okay? For ortho patients, I mean, we have to talk about like what is the incision site like, is there any infections or are they complaining about pain, whatever. I mean, we all know this, we do this, but we're just not charting it. And so I'm afraid right now, and I haven't done an audit right now really deeply, just looked enough to see that we're not really there yet, but I am going to start looking at it. I mean, and I do hope to have nursing meetings every month. I mean, that was our goal. I do want to keep that up, and at the next nurses meeting, I'll give you an idea of like what I've actually seen. So I'm giving you kind of like a heads up, like start getting those Medicare charting done correctly. The third thing I wanted to talk about briefly was IV. I did confirm with Ron's because they provide us with their IV policies and procedures that we follow. LVNs, so long as you are IV certified, and we do have IV checklist, competency list every year. So long as you have that IV certification and you've done your competency, you can start and discontinue IVs. You can flush with just normal saline, not with heparin. And you can hang just normal fluids that doesn't have, I mean, I think it can even contain vitamins, it said, but we normally don't get into that. It's usually for us, it's normal saline or B5W or whatever it is. You just cannot do any, as LVNs, you just cannot hang any antibiotics, even if it's in that little ball.
Potassium too, you can't do potassium, anything.
You
Any
can't-
medication.
You can't do,
No.
like, normal saline with KCL?
No, just normal saline, but without the
Just normal
KCl,
saline, okay.
yeah, without any potassium.
Okay,
Yeah.
anyway, if you guys have like questions about exactly what it is, I mean, there should be a Ron's Pharmacy IV PMP in the nurse's station. If not, I can make a copy and put it in there, but just kind of just think about it as, okay, no KCl and no antibiotics. And obviously even RNs don't do pushes here through an IV. And I think it's the same way, it doesn't matter if it's a PIC either, is the way I read it, correct, John?
Mm-hmm.
Yeah, so even with central lines, yeah, so, no, I'm just saying like, you guys aren't like limited with only just peripheral IV. You can do central lines like PICs and midlines and stuff. That's the way I read it. So, and I'll check on that again,
I
and
don't think
so.
we can do central. I'm just guessing.
It's the same, I mean, you're not, okay, you really, actually, I don't want my nurses like DCing central lines, any kind of PIC lines anyway, just call Victor PIC, but yeah, that's something I'll have to look at, and then I'll amend that in this afternoon meeting if I need to. And, oh, that's not on the subject, but I think the last time we had the nurses meeting, I was going on and on and on, especially with the night shift, sorry, Peter, about the call-out situation. I ran the reports again yesterday. They look better. The night shift still is like the least responsive, but it's not by like a lot like it was the last time. So good job, keep it up. I'll get a more formal report going again at the next nurses meeting in 2025, but I will be keeping a eye out on that. So again, you're, I guess, forewarned about that. and that's it for me.
I'll go over the ITSE real quick, just a little bit more here. When you're looking at the resident's name outside the room, you'll see the red little dot, and that's for fall, obviously, we know about that. The two dots right after that, the first dot is gonna indicate the diet order, okay? And so you can see in the
That's the
pyramid here,
Food
okay,
texture.
food texture. And then the next dot, the second one, right after the name, right? It's gonna be the fluid. So you'll see two different colors, and that's indicating food first and then fluid next. Okay, so we're gonna get asked. Trust me, we're gonna get asked during survey. I don't like expect 100% of us is gonna know every single thing, but I do expect us to have this to kind of as a referral and say, okay, this is what they have in terms of their, what their diets are. Okay. The other thing is that when there's a diet change, the resource nurse is responsible for communicating with the floor nurses to change these colors. So we do have little dots and stuff like that at the nursing station, but we have to make that change. Sometimes one resident can have multiple changes in 1 week, so we need to be changing those dots. We got to be on it because we can't get caught up where, oh, okay, you got puree diet on Matrix, but you have regular diet on her outside her door, and that could be a significant issue when the state surveyor comes in. So we just got to really communicate that. In terms of does anybody have any questions on that, by the way? Starting today, I'm gonna have somebody come in and we're gonna make like 100 of these. And so this is gonna be added in your name tag. And so the backside, as she said, is gonna be indicating, just kind of reminder what the red dot is for our fall residents. And then this is gonna be, there's a hole here and you're gonna attach it to your name tag. Okay, so we're gonna have a bunch of those prepared for you. Any questions on the ITSE?
And just to clarify, whoever takes off the diet order is responsible for getting those dots and changing it on, just put it right over. Don't try to take off the old dot, just put the new dot on the door. So normally speaking, the diet change orders will come to the resource nurse, but especially for nights, sometimes, as nice nurses, we take off the order. So then it will be on you, Peter, or Nadia, or Rahel, to take that order off, find those dots, and then change it on the door. Otherwise, everything's gonna fall apart. If everybody just assumes, well, I thought the floor nurse was gonna do it, oh, I thought the unit clerk was gonna do it. No, I want whoever's taking off that order to do it, okay?
Yeah. So, and the main reason why Amira is here today is because we want to go over charting in terms of Medicare. I know Jock went over it a little bit, but I'll go over it more in details. I made an example how Medicare charting should be and should look like. It covers everything on here. This looks very ominous. It looks very kind of scary. But really, if you've been charting for more than a year as a nurse, you should already know what the guidelines are, right? Very basic stuff: resident condition, orientation, vital signs, medication, how they took it, did they take it. Obviously, as Josh mentioned, focus on the admitting diagnosis, okay? So the treatments, you can mention that in your nurse's note. This nurse's note took me 3-5 minutes to do, right? Activities of daily living, that's really important. Are they getting up? Are they going to activities, right? On top of that, you have to mention ADLs with therapy. They're continuing to do skilled therapy. But most importantly, how are they transferring? They're gonna be looking at what kind of transfer assistance do they need? Is it extensive assist? Is it 2-person? Is it 1 person? These are things that Amira should be working on. We are going to be working with Amira in terms of how to audit Medicare charting, but it has to be done every shift. Okay, we have a little sign here. I'll put this in our little booklet, but also I'm going to be passing this around to our new nurses to kind of give them a good example on how to chart. And I'll go read over this real quickly because it's kind of like, oh, okay, I've seen these kind of charting on a day-to-day basis, but it has to happen in every single one of our residents. Good news is that our readmits has gone down significantly, and partly because we're doing a better job of kind of monitoring our Medicare patients. So I've seen a significant drop on our readmission, and it's because we're bringing it up, coming to light. Hey, you know what? Our readmission was really high at one point. Now it's come down, and it's partly due because we've been bringing up the issue. But most of that has to do with really monitoring our patients that was admitted in the last 30 days to make sure that they don't go back to the hospital, and that means kind of really monitoring their condition. So pain management, of course, you're gonna mention that, right? How they're eating, how they're drinking, bowel movements. and then there's safety protocols. So just kind of give you example of how I did this. Patient remains A0 times 4 with stable vitals. You can choose to put vitals in there, but it's already in matrix, so you can just say it's stable, right? If it's not, then obviously you're gonna have to do a change of condition. How did they take their meds? They took all their meds without issues. And then this one in particular, this patient, I focused on respiratory. Okay, so I'll go over real quick because Medicare has specific guidelines on how to chart on patients that have respiratory distress, right? I put in here on continuous O2 via nasal cannula at 2 liters per minute. And then you want to mention that you kept that head of bed up. That's really important when somebody's on respiratory distress or comes in with COPD. Anything respiratory, you keep the head of bed elevated for comfort. No complaints of respiratory distress. The shift breathing is unlabored, it's even. And then what kind of treatment are you doing? We're continuing with DuoNeb as ordered, continues on antibiotics maybe because they have pneumonia, right? And there's no significant adverse effect on that antibiotics, right? Maybe a little bit of wound care. What did you do? Maybe they got a wound care, right? They wound care to left lower extremity completed, and you can put a little bit of, of what you saw in there. If you didn't do any wound care, obviously you're not going to mention that. Medicare is really kind of, they look at every little details on the Medicare, right? So you're gonna mention a little bit of wound care if you did, and then you're gonna mention here, as I mentioned here, resident up for all activities this shift. She required extensive assist times 2 staff with transfers and showers, independent with meals at their setup. And then you're gonna mention pain, right? Was she in pain or was she not in pain? No complaints of pain, or I gave her Tylenol times 1 for mild pain, or for headache, right? She consumed 100% of her meals. She remains continent with bowel and bladder and voided times 3. No significant signs of dehydration. She remains at fall risk, and then we kept her bed low, and we have bed and chair alarm in place. So these things are really important, but the most important thing is we focus on the diagnosis with respiratory, her comfort, pain, and then her ability to transfer. So if you're gonna focus on 3 things, it's gonna be diagnosis, orientations and vitals obviously, but her ability to transfer and walk around is gonna be really important because we have to show, are you improving physically, right? And that's gonna show right here. Right, we admitted her. She required times 2% assist, and now at the very end of her discharge, she's independent now. You know what I mean? So yeah, this looks like it's a lot, but when you're really thinking about it, it's kind of condensed, And then and you can look at other people's charting, but took me maybe 3 minutes, and I made up some stuff, but I'm kind of used to Medicare charting and how it looks, but you just want to mention orientations, vitals, the main diagnosis, and their ability to transfer and pain. Okay, and it could be statical surgery, and you're to focus mostly on how that's doing in terms of your charting. Okay, so I have this example here, the compliance here, but the charting has to be done, Medicare charting. That's why Mary's here every shift, and so and what we're concerned is that we're missing a Medicare charting for the whole 24 hours, and that's not good. We're gonna get in trouble for that. And that's why it's pertinent that we do Medicare charting every single shift. Okay, and now we had policies before when we kind of charted, odds and evens. We're not gonna do that because it's too much, and nobody can remember. Oh, is it even? Is it odd? So we're gonna go back to the standard charting, which is Medicare charting every shift. Okay.
If I can just
Yeah.
butt in here for a second. One of the things that I was looking at also was looking at the charting versus the weekly summary charting. And right now, we're falling behind a little bit on that because I do know how the weekly charting's done. You can just copy with a click like the previous things, a great majority of it. So what I saw was more times than I wanted to, where the weekly charting didn't match up with what the progress notes were. We can't have that. I mean, because just think about it. If you're an auditor, you're a surveyor, you come in, somebody's lying, right? So just be very careful with that. And I know the weekly charting can be tedious or whatever, but just be aware of your resident, and just be more mindful, because I like I said, I saw too many of that where you're just copying and you're just counting the behavior, monitoring things. I mean, I know how it goes, but we have to be much more mindful of it. We have to be mindful of, like, try. We really do. So, all right.
Yeah, so the rest of the stuff is like resident eating in bed. So we got to make sure as nurses we should know what the like basic stuff is when patient has to eat in the room, head elevated. But you as a nurse also you should already know that like most of these patients should be up in a way, right? So if you have a CNA that's not up to par with getting the residents up, you got to be on them. Hey, get your residents up. Why can't you get them up? What's the reason? Why? Okay, let's be let's be not aggressive, but we gotta take charge of the resident because they'll say no to everything. They won't get up, right? But we've had some issues with patient laying in bed and having, aspirations or whatnot. But we should know the basics in terms of when a patient is eating in their room, they should elevate their bed, okay? But most importantly, we should get these residents up for meals in a way. Okay. The other thing is,
So the elevating the bed, what we're hearing as nurses and dietary and therapy are pointing us out, rightfully so, because what they keep seeing is, yeah, the bed itself is up, but the patient is positioned so that they're not sitting up. Raising the bed up isn't the point, it's having the patient, so their whole point was, well, why can't they just eat in a chair? So that's not an issue. So that's what we're coming up with, because I think a lot of the CNAs, they should know better, but they think, yeah, well, I raised the head of the bed. No, that's not the point. You need to raise the head of the resident. So just keep an eye out on it, and I mean, I honestly do believe that CNAs are hardest working people here. We have to, it's not an adversarial relationship, but we do have to remind them sometimes, hey, just think about it. So, all right. So-
yeah. So and then the other thing is medroom. Looks like we've cleaned up the medroom quite a bit from starting yesterday. Ricky was on it. It looks pretty clean, but any medication that's taken off the floor can't be put in the medroom. We have to get rid of it. We just can't be stocking medication, and the patient was discharged. Always leave it here. Okay, so have the nurses on the floor destroy it before when you see them come in. They say, hey, don't leave it there. Go ahead and destroy it. You know what I mean? Otherwise, the resource nurse has to do them. So if you're sitting on the even when you come in on knock shift, right? You see a PM nurse, have some medication they're putting in the bedroom. They have to destroy. They can't leave it there, right? Because then that falls under the resource nurse workload. We have to keep that bedroom nice, clean and clear. Okay. Also, the cubics we are gonna have pharmacy consultant or somebody that's doing
It's a pharmacy board that's coming in to do a inspection for Ron's, which is now bought up by Guardian or whatever. So it's the pharmacy board that's doing the inspection, I guess.
So I sent a little training yesterday regarding the cubics to kind of get everybody kind of up to date. And I'm just going to be asking people for signature to make sure that we are, we're familiar on how to use the cubics. And then I put holiday staffing in here. This is kind of is out there. We're trying to fill all of our requests for the holidays. And just kind of reminder that holiday is one of those where we can't request, but if you do and we can fill it, we will do it for you, okay? And we have a couple of nurses that have started, and I have another one next week that's going to start. So hopefully, all of our requests are going to get filled. Okay. Any questions on anything? Try to keep it nice and sweet. It's under 30 minutes, so just in case.
Okay, good.
Yeah. Okay. And then I'll start, asking this out when we're done.
So for me, I know just to make sure. So for the the PTOT, it's not happening during the night. So do we still need to mention that?
No.
Or just mention whatever is gonna happen during
Whatever is on your shift.
Yeah.
If you know for a fact, if Jolinda is still giving the report, you can write down patient receiving PTOT during daytime or whatever. But don't write down anything that you don't know yourself. Okay? But you do know yourself if you see that you got reports saying that they're participating.
Yeah, but it's in the order too. What I did before is that I would look at the order. Like before I say continuous and skilled therapy, I look at the order, because skilled therapy is usually on order, right? Under the resident orders, and it'll put a stop time in there. It'll be usually for 31 days, you know, Medicare, and it'll be from like August till September or whatever, and it has an end date. So if the order is there, it's clear, skilled therapy, then you can say, hey, you know, continue with skilled therapy. So,
And one more thing, if I mention that when the patient is released from Medicare charting, we need to check on the area on the face sheet that it says the private pay or not, because if they're on private pay, that means the skilled has finished. So you can't do Medicare charting, that will get us in trouble also.
What are you talking about?
What I'm saying that if the patient is the last covered day and is finished, but they're still here private pay until like they have to go home or whatever, they are not part of the skilled anymore. They're private pay, they're regular pay. We cannot do Medicare charting on every
Why
sheet.
not? We can do Medicare. Medicare charting is like the gold standard, so I don't have a problem. I don't want them to
Okay.
get confused,
Okay.
saying now they're private pay, so we're not going
Because
to.
Satomi was, MDS was telling me that they are gonna, it's causing trouble for them to
Must.
continue.
yeah, so here's the thing, with Medicare chart, it'll, if you chart resident who's not Medicare anymore, it'll still cover like a majority of,
Okay.
you know, the services that we provide, so it'll still be fine.
Okay.
Where we get in trouble is we say, you know, the patient requires extensive assist and they're only one person assist. You know what I mean? So that's where we get in trouble. But in terms of like even doing this kind of charting for everybody that like, is specific to the resident, we can do that. It's fine.
That would be
Yeah.
great,
Yeah.
if they had time to
Right.
do
Yeah.
like Medicare charting, because that's actually,
This is
Chart.
something Satomi brought it to my attention a few months ago, that,
okay,
as
well,
far as MDS, so.
Yeah. All right. Any questions? Any questions? Okay, perfect. All right. I'm gonna stop this right here. This is a pretty good video.